My name is Hamid Eftiari. I'm delighted to be here, and it's just great to be presenting after Kathleen Brady, who is a great mentor for me for many years. So I'm learning a lot from her. So we are discussing about other things that we probably can do with RTMS. I'm going to discuss mainly about frontopolar cortex and potentials with frontopolar cortex. So as you know, there are ongoing an increasing number of trials people are using with different sort of non-invasive brain stimulation technologies. As you can see over the time, we have a good amount of evidence that it seems that these technologies are working. As you can see, it's interesting that after nicotine and alcohol, meth is the most frequent substance to be explored with different kind of brain stimulation technology, followed by cocaine, opioid, and cannabis. So that is the kind of the progress in the field, as you can see. But as a side note, it might be interesting for you that it is not us in the US that we are the only kind of country that is making evidence in this specific field. As you can see here, people in China, they are producing like 23% of the literature in the field, while we are making like 24%. So it's quite interesting. It's also important for us, especially as we are discussing about methamphetamine and stimulants. 27 trials are of using brain stimulation technologies using amphetamine happened in China compared to 3 of what we have in the US, which is quite interesting to see. And that is the reason that we made a network of labs around the world that are doing brain stimulation trials to be able to work together. And we already have 54 lab members, including kind of multiple labs from China that are collaborating in that process. So trying to see how we might be able to do 2 things together. We have a meeting in New York in end of July, so that we are trying to bring people together and see how we might be able to do things together. And it might be interesting for us, another side note, that UN is making a specific meeting on next Monday discussing about potential treatments for stimulant use disorder and how we can collaborate in the global level. And US State Department is a part of that initiative. I mean, people from Japan, China, Brazil, they are collaborating on that initiative. And within the International Society for Addiction Medicine, we are also working in terms of bringing people together and see how we might be able to do things together in the global level. So there are definitely potentials on those things to kind of explore. But going back to what we have been discussing about addiction and different targets, people try different targets for neuromodulation for addiction, as you can see here. We published a new paper in the last issue of American Journal of Psychiatry discussing about frontopolar cortex based on the new findings from Michael Fox's lab about a lesion study that they showed that frontopolar cortex is going to be an important area for neuromodulation. Also kind of findings from Colin Hanlon's lab about kind of alcohol and smoking, and also what we have in our lab for methamphetamine use disorder. It seems that neuroimaging data support the idea of targeting frontopolar cortex, and also multiple successful trials when we do head modeling in terms of where they are actually delivering the electrical current. Frontopolar cortex is definitely targeted in some of those trials. So it is important to consider that as a potential target for neuromodulation. But going to those targets, of course, DLPFC is the most frequent target, as Kathleen has mentioned. But frontopolar cortex comes next. And there are 16 trials or experiments, actually, that people have done so far targeting frontopolar cortex. 4 of them are on cocaine, 2 of them on meth, and 2 on alcohol and cocaine. So there is some pieces of evidence that people have tried to see. And let's see what are the outcomes that we have and what are the characteristics that we have in these trials. So among those 16 experiments, 8 of them are using CTVS protocols for targeting frontopolar. And CTVS protocols are inhibitory protocols. So they are basically targeting frontopolar cortex to suppress frontopolar cortex. And then there are deep TMS protocols that they are using H7 code specifically. But with CTVS protocols, most of them they are using figure of 8 coils. And this is the most frequent coil. And even double cone coils are actually figure of 8 coils. So this is the most frequent coil that people are using for targeting. And left frontopolar cortex is the most frequent area for targeting, as you can see here. And then most of the studies, they use basically a scalp-based EEG measures to kind of find frontopolar cortex as some like FP1. So they use basically SCOP-based measures based on the EEG 1010 system to find frontopolar cortex. So this is kind of an overview about what people have done. And in terms of outcome measures, these are the outcome measures that people tried in their trials. As you can imagine, craving is the most frequent outcome measure that people explored. Physiological measures like fMRI, EEG are things that people have explored. And afterwards, we have consumption, relapse, abstinence as the most frequent outcome measures, and with different protocols and also different substances. But in terms of the findings that people have done, so far, as you can imagine, many of the findings that people reported are positive outcomes. There is only one negative outcome that is being reported, and that one was basically, as you can see here, on craving with a CTBS protocol, probably in opioid users. So that is the kind of the outcome measures that we have and the outcomes that people have reported. As you can see here, another figure around the same topic. There are multiple positive outcomes that people have reported, but targeting left frontopolar cortex with CTBS was the most kind of explored area, and they have some like 11 positive outcomes that they reported with different outcome measures, as you can see here. Okay, so in terms of the frequency and the protocols, as you can see here, people used 10 hertz, like Kathleen Brady kind of discussion about kind of the targeting, but CTBS protocols, which are using mainly kind of 50 hertz stimulation, specific pattern stimulation, are the most frequent things. And people have used different numbers of pulses. The highest number of pulses would go to 3,600. And there are 3 trials using CTBS or 3,600 that they kind of, this is the maximum dose that people have explored. And we know that probably cue exposure and cue provocation would be helpful to have better outcomes. As Kathleen mentioned in her presentation, they are doing the same in terms of kind of exposing people to cue-related pictures and even kind of imagination. And this is pretty frequent in the field that people use that compared not to kind of expose people to drug-related cues. And one of the kind of the things that we are doing in my lab, basically developing different databases for cue exposure and optimizing cue exposure paradigms. So that's another thing that we are trying to optimize in what we have. But going back to number of sessions in the trials that people explored, as you can see here, there are some single session trials, but we also have trials that they explored multiple sessions. So there are trials with, good chunk of number of sessions, up to 20 sessions. So that is the highest number that we have so far. But how to optimize the protocol? What is the best protocol that we can use? And what is the potentially kind of best area to bet on for targeting frontopolar cortex? In my lab, I'm interested to do individualized optimization using robotic arms and doing imaging before and kind of targeting a specific connection with amygdala. So that is what I like to do in my lab. And this is a trial that we are already running, but that is probably not the best case for CTN based on the infrastructure and other things that we have in other labs around the world and around the country. So that is something that we are probably not going to do in CTN. But the idea of not only frontopolar cortex is going to be important, also DLPFC is an important target. So we are showing in different studies that, probably targeting both frontopolar cortex and DLPFC could make the effect that we are exploring. So stimulating DLPFC and suppressing frontopolar cortex. So that is probably the best network that we can target. And that is what we are doing right now in terms of even trying to optimize that in individual level for DLPFC frontopolar cortex. So even there are potentials thinking about, should we target not only frontopolar cortex, but also DLPFC, and thinking about, should we think about some like a 3 arms trial, or just think about one trial? So that is going to be another discussion to see what is going to be the best way to do it. But it seems that kind of frontopolar cortex and DLPFC, they are potentially the best targets. Interestingly, a group of colleagues in China, Min Zhao, she's one of the key figures in the field, Shanghai Mental Health Institute. They ran a pilot study with the same idea in terms of targeting DLPFC with ITBS, which is a stimulatory protocol, And VMPFC is basically the same, frontopolar targets, and it is basically from FP1, so that is the left frontopolar cortex, with CTBS, which is an inhibitory protocol, a group, a combination, and also sham. So they had the sort of luxury of doing a 4 arms trial, and they have their initial outcome, and this is what they have in 2 weeks of stimulation, 10 sessions of stimulation. So this is what they did. And as you can see here, this is the blue one is sham. And then all 3 groups, they had significant level of craving reduction. Of course, you can see that the combined group, which has both DLPFC and frontopolar kind of targeting, there is a trend that is kind of even more effective compared to others, but this effect is not significant. But all 3 groups, they showed significant reduction in the level of craving. And they defined a specific measure in terms of treatment responders, those who had 60% of craving reduction as sort of treatment responders. And they showed that the combined group has a significant treatment response to what they basically targeted. So that is quite an interesting trial, showing some initial things that could support the idea that we have been discussing. But thinking about the dose, I mean, learning from what people have done in depression and large databases in depression. Right now, we have some like this study, tried a database of over 7,000 people received a stimulation for depression. They showed that probably the first 10 sessions we have the highest response in depression. But they realized probably the optimum number of sessions would be at least 30 sessions to be able to get to the kind of the top effect. And all the kind of studies or all the kind of the treatments that they received less than 30 sessions, they have not been able to compete with 30 sessions of brain stimulation. So the idea of higher doses and more pulse kind of per session is something that we can discuss about how to optimize the intervention. And thinking about the timing, this is the BrainsWay nicotine protocol that received FDA clearance. So what they did, it was some like 5 sessions of intervention every week for 3 weeks, and then 3 weeks for some like boosting sessions. And the protocol, they had cue provocation, TMS, and also some sort of brief counseling, as Kathleen mentioned, in terms of adding some behavioral interventions at the end. So that is going to be another discussion in terms of what is going to be the best package that would be working. Meanwhile, we can kind of go back and see what people have done so far with TMS depression protocols that they received FDA approval. As you can see here, the initial protocol, the initial RTMS protocol was around 40 minutes of stimulation. And then the ITBS protocol that received FDA approval, it is something like less than 5 minutes of stimulation. And SAND protocol, I mean, they changed the name right now. I mean, the protocol, but what they are doing is basically something like 10 minutes of stimulation. So that is another 10 minutes of stimulation. And BrainsWay protocol is something like 20 minutes of stimulation. Based on my measurements from basically the CTN, Kathleen Brady, and also Dr. Trivedi trial, their trial should be something like 20 minutes of stimulation. And what we are suggesting with something like 3,600 pulses, it would be something like, because it is CTBS, ITBS, it would be something like 8 minutes of stimulation. So, and we can discuss about the technical details of how that protocol should be functional. But we think that the timing would be reasonable in terms of it is going to be shorter, and hopefully that is going to be close to what has been basically approved by FDA before. So that might be helpful in that process. So just kind of the last slide, some take-home notes. So we can discuss about what is going to be the ideal scenario. Are we going to have 3 arms trial, double arm, or even more complex 4-arm trials? And then the treatment context, cue exposure, what is going to be the brief psychological intervention? What are the ways that we can do dose optimization? So that is going to be another discussion. Potentials for accelerated TMS protocols. Hopefully Nolan will discuss about accelerated TMS protocols, and we are interested to that side as well in terms of running multiple sessions per day, up to some like 10 sessions per day. And then think about sham protocols and COIL, and also predictive modeling, as Kathleen mentioned, in terms of using biomarkers or even some behavioral measures to predict who is going to be responder to DLPFC or frontopolar stimulation. So there are definitely potentials on that side. And many thanks to colleagues and collaborators who helped me to present here, including my postdocs, who basically made the slides and put things together. Thank you very much.